And today she's going to present her exciting work on developing a drug delivery system for venous malformations. So with that, I'll turn it over to Kathleen.
Thank you so much. Thank you for the opportunity to share this work. We have been working for a couple of years now to develop drug delivery systems for venous malformations. And just in case you're out there thinking, what is an intensivist at Boston Children's doing making nanoparticles for venous malformations? I figured I'd describe a little bit about the inspiration for this project, but then also give a little bit of a history as to what we've been doing the past couple of years. So the inspiration came when I was a fellow working in the ICU at Boston Children's under my attending, Dr. Dan Kohane, who is now my mentor. And we were beginning to see more patients coming through the ICU with debilitating vascular malformations as our vascular anomaly center in the hospital grew and grew. And we were really kind of struck by, at that time, the limited treatment options for these patients. And so we started on this journey that I will describe. Let's see if I can get my slide. Okay, so many in this group probably know that vascular malformations, that term is an umbrella term that describes many diseases that have abnormal development of blood vessels. And there are a number of types of vascular malformations. They can be classified as simple or complex, and they can include the abnormal development of veins, arteries, lymphatics, or capillaries, or a combination of the two. And there are many more permutations of this, of course, as well. And for points that I'm going to make throughout this talk, we decided to focus our attention on venous malformations in particular for a few reasons. Number one, they're the most common vascular malformation. Number two, they're a slow flow lesion, and I'll explain later why that's important in nanomedicine. But venous malformations are present at birth and they grow as children grow. They can be associated with disfigurement and life-threatening issues such as pain, obstruction of organ function, bleeding, thrombosis. And you can imagine the symptoms that patients describe are largely dependent on where the venous malformation is located. And at least at the time that we started this work, the treatment options were limited and depended a lot on where the venous malformation was located. We noticed that they were largely supportive care, meaning compression garments. And if you happen to live near a large, tertiary or quaternary center like UT Southwestern or Boston Children's, maybe you could have ablation of your abnormal vessels with sclerotherapy or surgical resection, but there are a lot of complications with this, hemorrhage, etc. And unfortunately, regrowth of these malformations, even after these procedures, was common. Luckily, we know a lot more about venous malformations than we knew the 6 and 7 years ago where we started this project. But researchers and scientists and clinicians have determined that the Tie2 PIK3CA pathway is important in these patients. So more than 20 gain-of-function mutations have been found affecting the Tie2 receptor. And the Tie2 receptor is found on all blood vessels, but is abnormally activated in patients with venous malformations. These mutations can induce a ligand-independent phosphorylation and therefore downstream activation of this pathway. Hopefully you can see my pointer. And that's about 60% of the patients. In the remaining 25% of patients that do not have identifiable Tie2 mutations, mutations are frequently found involving PIK3CA, which also activates or constitutively activates this pathway. And so this is data that suggests that the Tie2 PIK3CA or PI3 kinase pathway is essential, or at least important, in the formation of venous malformations. There are inhibitors to this pathway. There are specific PI3 kinase inhibitors and also inhibitors to mTOR, which is called sirolimus. These have been identified and used in other different diseases. And with this information, clinicians began treating patients with complex vascular malformations with sirolimus, an mTOR inhibitor, which showed efficacy in halting the growth of the VMs. It was important to note that many of the VMs did not regress, but they didn't grow, they didn't expand. However, they did report in this paper, and we've seen it in patients that we're caring for, that patients report side effects, even with short-term exposure to sirolimus. They report mouth sores, GI upset, increased risk of infection, and that could be secondary to immunosuppression, and also cytopenias. And when this occurs, patients often stop taking the sirolimus, and when they stop taking sirolimus, the VMs start growing again. And it's not entirely surprising that this happens, even with a molecularly targeted therapy. And that's because even when drugs are delivered IV or orally, only a very small amount actually reaches the target tissue. And instead, most of the drug goes to these bystander tissues, the healthy tissues that you don't want to be targeting, and causes these unpleasant symptoms. So we were curious 6 or 7 years ago, we were curious to see if we could develop a different drug delivery system that could be delivered systemically as depicted here, but would actually increase the amount of drug at the target tissue, specifically at venous malformations. One way to do this is with nanoparticles. Nanoparticles, as the name suggests, are just small particles, and they can be used to encapsulate drugs within them or therapeutics within them, and work as a drug depot, slowly releasing the drug or the therapeutic over time. They can be designed to be small enough to pass through vasculature such that they won't cause occlusion or embolus. And they can be made in different shapes or sizes, as I depicted here. So these are just 2 different types of nanoparticles. And the shape and the size and the type of nanoparticle that you design can help you encapsulate hydrophilic versus hydrophobic drugs. You can encapsulate siRNAs, peptides, or antibodies. You can encapsulate drugs within the nanoparticle drug delivery system, or you can conjugate some of those therapeutics to the nanoparticle drug delivery system. And nanoparticles can be targeted to specific tissue. And this can improve drug delivery to target tissue, and therefore could theoretically improve the therapeutic index of the drugs that you're working with. One way that nanoparticles can improve drug delivery to target tissues is via this concept called enhanced permeation and retention, or the EPR effect. And this is that when nanoparticles are administered intravenously, nano-sized agents will often preferentially accumulate in organs with leaky vasculature. This is the EPR effect. EPR is an example of passive targeting, where the nature of the particle and the nature of the tissue can encourage particle accumulation. EPR has been documented in many models, many cancer models, models of myocardial infarction. And the concept here is that when the vasculature is normal and you inject a nano-sized agent, then nanoparticles should continue to circulate through the vessels and should not kind of dwell in target tissue. However, if vasculature is abnormal or leaky, nano-sized agents, when administered systemically, could kind of dwell in target tissue and again act as a drug depot, kind of sitting there and releasing drug over time. Now, when we started this project, no one had applied concepts of nanomedicine to any of the diseases in the vascular malformation world. A lot of people were developing drug delivery systems in many other models, like in cancer models, but not in the vascular anomalies or vascular malformation world. And venous malformations from a histopathology perspective were particularly interesting to us because they had many characteristics that could be amenable to the EPR effect. Those characteristics I'm talking about are the fact that the vessels of venous malformations are large, they're ectatic, and the walls of the vessels are very thin. The smooth muscle that kind of surrounds the vessels is disordered. So again, maybe the vasculature is leaky, and then the flow is slow. So again, potentially could help nanoparticles kind of dwell within surrounding tissues and act as a drug depot. no one had specifically studied EPR and VMs, but supporting this idea, this is an example of a radiograph taken of a patient 60 days after they had nanoparticulate iodine-based contrast material injected for a kind of a venogram. And they came back into the ICU, and this was many days after that contrast had been administered. And you can see with the red arrows that there's contrast material that's abnormally kind of dwelling in the vasculature. Again, possibly suggesting EPR occurs in these vessels. So that's one way that nanoparticles can get to target or disease tissue. Another way is through concepts in active targeting. Now, in the nano world, this is very complex, and I could do a whole talk on active targeting, but just to get to the basics, to kind of break down what we did in other experiments, there's kind of two different ways that you can actively target nanoparticles to a tissue. One is if you have a disease-specific ligand. So if you have a disease-specific ligand, you can decorate your nanoparticle in that ligand, and you can inject your particle systemically in any cell that doesn't have the receptor. The nanoparticle should not bind. However, to cells that do have the receptor that sees that ligand, that would facilitate nanoparticle binding and then endocytosis. But what happens if you don't have a disease-specific ligand? In this case, you could decorate nanoparticles in a cell-penetrating, in a peptide that most cells will identify and would promote endocytosis. So there are a number of these. And then you can protect that peptide with a caging group. So the caging group is kind of highlighted here in blue. And so if you inject this particle systemically, the peptide is covered by the caging group and no particle should bind. However, the important point here is the bond that connects the peptide and the caging group should be one that is released with energy, such as ultrasound, magnet, light. And in that case, when you apply the energy, the bond should break, the peptide should be free, and particles should bind. So we were excited to maybe design a drug delivery system that could be targeted to just target vessels. And as I mentioned, the Tie2 receptor is abnormally activated in VM cells, but unfortunately, it's not a disease-specific receptor. Other blood vessels express Tie2, so that's really not a method we could use. The second tiny detail was, at least when we started this work, we also didn't have a mouse model of venous malformation. So we didn't have a disease-specific model, a disease-specific target, and we didn't have a mouse model. But as a proof of principle, we did have access to a model of bioengineered vessels in mice. This is a model that was generated by Juan Malero Martin at Boston Children's. And in this model, he uses stem cells, endothelial colony forming cells, and mesenchymal stem cells, combines them in a hydrogel and injects them subcutaneously into immunodeficient mice. This is not a VM model, but it is a model of neovascularization, so a model where new blood vessels are forming, and we could see if we could target our nanoparticles just to those newly formed vessels. It's also a great model because these newly formed vessels are connected to the host vasculature, so it allows us to inject systemic agents. So we designed the following particle. We decorated nanoparticles in a ligand that any cell should recognize, a cell-penetrating peptide called TAT-C, which is derived from the HIV virus, and then covered that cell-penetrating peptide with a caging group called DEACM. And then we added a fluorophore to the nanoparticle to allow us to track the nanoparticle in vivo. And the most important part of this system is that the cell-penetrating peptide, which is depicted here, and then the caging group, that DEACM, are connected by a bond that is photocleavable. And upon irradiation with 400 nanometer LED light, so not visible light, but LED light, the bond that connects the peptide and the caging group should break, and the peptide would be accessible. And so the technology here is that we can inject the nanoparticle systemically, the caging group will be bound, and the nanoparticle will not bind. However, in any area that we irradiate light, like a bioengineered vessel network, Hopefully, the caging group should be removed, the peptide would be exposed, and the particle will bind. So to test whether this system would allow us to specifically target blood vessels and not deposit nanoparticle in all vessels, we designed the following experiment. We took mice and we made human vascular networks, that subcutaneous model, 2 networks on each mouse. We then injected mice with either saline, free dye, or our nanoparticle that I just described. And then to one flank, we irradiated the animals with light, and to the other, we did not. We then 24 hours later, we excised the human vascular networks, and then we measured the fluorescence that we saw there with IVUS. Without irradiation, so this bar, hopefully you can see my pointer, we detected 4 times more fluorescence compared to free dye. So this suggests that nanoparticles will passively accumulate in the human vascular networks, probably because in the neovascularization phase, these vessels are leaky. But then when we shine light with photo-targeting, we can enhance nanoparticle accumulation, or at least fluorescence, 17-fold. And we published these findings in Nanoletters a couple of years ago. And we felt like these data really supported the idea that we could develop a drug delivery system to effectively target specific vasculature, like the abnormal vessels that comprise VMs. And so this prompted us, with actually Joyce Bishop's help, who's on this call, I think, prompted us to collaborate with Elisa Boscalo at Cincinnati Children's, who developed a model of VMs similar to the bioengineered network model. And I believe she's spoken at this talk before, so I won't go into the model extensively, but just to highlight that, as I mentioned, 60% of patients have the TIE2 mutation, the most common being L914F. This activating TIE2 mutation is sufficient to induce human umbilical vein endothelial cells, or HUVECs, to form VNs in immunodeficient mice. So in this model, the TIE2 mutants, TIE2L914F expressing HUVECs, are suspended in Matrigel and then injected into immunocompromised mice. And within 10 days, these mice develop vasculature with similar characteristics seen in patients. As you can see, we've outlined the blood vessels here, but the blood vessels are very large and abnormal. And you can see here the lesions are very blue and more dramatic than the other model for sure. So the first question we had was, does EPR occur in this murine model of venous malformations? And if so, what's the optimal nanoparticle size that will facilitate accumulation in VMs in mice? So the backstory here is that there's a trade-off between nanoparticle size and accumulation in tissue. Smaller nanoparticles tend to have improved deposition within tissues than larger nanoparticles, but they can be loaded with less drug. Larger nanoparticles can be loaded with more drug, but may have less passive accumulation. And it's impossible to know which nanoparticle size will be optimal for passive accumulation before doing the experiment. So to do this, we developed nanoparticles ranging in size from 20 nanometers to 180 nanometers. And then we conjugated them with a fluorophore, again, the same one, Alexa 647, to allow for in vivo tracking. And then this is just transmission electron microscopy, demonstrating each of the 4 formulations we made. So a 20 nanometer, 50 nanometer, 80 nanometer, and 180 nanometer formulations. And I should mention, at least in the cancer world, greater than 250 nanometers, generally the EPR effect does not occur. We then injected each of these formulations into mice that have VMs, and then 24 hours later, harvested the VMs and measured the fluorescence using IVUS. We found the greatest amount of fluorescence in animals that were injected with the smallest nanoparticles, 20 nanometers, and that fluorescence was greater than those that were injected with larger nanoparticles, 180 nanometers. This is the data like fresh off the IVUS machine. But here the data is depicted when we normalized for the size of the venous malformation. So we normalized per gram tissue of VM, and then we also normalized to the quantity of the fluorophore that was conjugated to the surface of the particle. Because as you can imagine, smaller particles may have greater surface area compared to larger. But again, as you can see, the trend here is smaller nanoparticles tend to have more accumulation, at least passively, than larger nanoparticles. We confirmed these findings by confocal microscopy.
Kathleen, sorry to
Sure.
interrupt. I was
Yeah.
just curious if I was wondering in that previous experiment if you collected other tissues like the liver to see if there was accumulation in other tissues.
Yes, we do. We absolutely do see accumulation even at the smallest size and largest size. We do see accumulation in other organs, and that is common with any nanoparticle drug delivery system. So I will say the disclaimer with nanoparticles is you're not going to have, the disclaimer is we don't have 100% of the nanoparticle going to target tissue, but we have a significant increase going to target tissue. So when you think about therapeutic index, like the portion or the percentage going to your target tissue compared to bystander tissue, the therapeutic index should be improved with nanoparticles. But yes, 100% correct. We just submitted this for publication, and we did show that you do see nanoparticle go to other tissues.
Thank you.
Yeah, no problem. So we confirmed these findings with confocal microscopy. And again, this data suggests that EPR does occur in a murine model of VMs, which is exciting, and that the smallest particles have the most accumulation, more accumulation compared to larger. So using these data, we are developing photo-targeted systems that I described earlier. And we're using these systems to load with chemotherapeutics, and we're testing them in vivo. And I hope the next time I'm invited to give this talk or something similar, I can show you that. Not quite ready for prime time. But we also use this information to kind of design the next experiments. And this is the final kind of portion of my talk, which is an entirely new concept to treating venous malformations. So we're interested in the concept of photothermal therapy as a treatment option for venous malformations. And I'm just going to go through the concept first and then talk about what we did. So basically, photothermal therapy is using heat to kind of cauterize tissue. And basically, what you do is you inject a photothermal agent, ideally systemically, and then that agent would passively accumulate in target tissue, again, by concepts similar to EPR. And then you use an energy source like near infrared light, and you apply it to target tissue. And then that agent will absorb the light and convert it to energy, and convert that energy to heat. That will induce a local hyperthermia and could ablate surrounding tissue. Photothermal therapy is an effective and non-invasive alternative to pharmacotherapy and is being used in a number of different diseases, including a phase 3 clinical trial for prostate cancer. And we hypothesized that we could design a nanoparticle-based photothermal therapy type approach to treat venous malformations. So to do this, we designed gold nanoshells. And we chose gold, not because I was trying to, make it as complicated as possible, but because from a photothermal therapy perspective, gold is great because it's biocompatible, it's non-toxic, and it's very responsive to near IR light. And folks have used gold nanoparticles in a number of different models, like making vaccines and delivering drugs, et cetera, and have demonstrated that gold nanoparticles, even if they deposit in bystander tissue, are very safe and non-toxic. So we made these gold nanoshells and then we characterized them. And the most important thing we were looking for was size. So again, we tried to make the gold nanoparticles within that size that would optimize EPR, so the 20 to 50 nanometer range, which we were successful in doing. And then we determined that these gold nanoshells had the maximum light absorption between 700 and 900 nanometers, which is the near IR range, which was great. So then we characterized these gold nanoshells in vitro. And basically what we did in a test tube was we took different concentrations of the gold nanoshells and heated them with either with one power intensity of near IR light, and then measured the amount of temperature change that we found. And again, we did a similar experiment by choosing the maximal concentration, 200 micrograms per ml of gold nanoshells, and then irradiating them with different power intensities of near IR light. And basically, the most important concept from these slides is that our system is titratable. So it seems like the amount of heat that we can generate depends on nanoparticle concentration, but also kind of power intensity of the near IR light that we apply. We also did an experiment where we took nanoshells in a Eppendorf tube, irradiated them with near IR light, measured temperature change, and then removed the light, and documented that the temperature increased when we irradiated the nanoshells, would decrease when we removed the irradiation, and we could repeatedly trigger these nanoshells to make heat. We injected the nanoshells into animals that had VMs and measured the pharmacokinetics by obtaining blood samples and measuring the amount of elemental gold by inductively coupled mass spec, or ICP-MS. And basically what we found was after we inject the gold nanoshells, we can detect gold nanoshells in the blood, but after 24 hours, we can detect very little gold nanoshells in the blood. But we can detect gold nanoshells in the VMs, and to your point, in other organs for sure. And we can identify the gold nanoshells by histology in the VMs. So again, we had demonstrated that VMs have EPR in our other experiments, but we also demonstrate here that these gold nanoshells will accumulate by EPR. So we set up the following experiment. We treated animals that had VMs on either flank. We treated them with either saline or gold nanoshells, and then we irradiated just one of the VMs, leaving the other as the control. We measured the heat that was generated when we irradiated the VMs, and we found that if animals were injected with gold and treated with near IR light, we saw a greater than 10-degree centigrade increase in heat at the VM. And so this was the real experiment. So we have 4 treatment groups. We have animals that are injected with saline, animals that are injected with saline and treated with light at the VM, animals injected with gold, and then animals injected with gold and treated with light. These first 3 groups are our control groups. And in those 3 groups, the VMs grew and actually tripled in size during our treatment study period. However, animals that were injected with gold nanoshells and then irradiated with near IR light just at the venous malformation, the venous malformation not only stopped growing, but started regressing within 48 hours, pretty significantly. At the 20-day mark, we euthanized animals, removed the VMs, and measured the weights. Animals that were treated with photothermal therapy, so our treatment group, the mean weight of venous malformations was about 8 milligrams. And in the control groups, the weights of the VMs was approximately 300 to 400 milligrams. This is what the VMs looked like. So these are just rows, and these are our different treatment groups. So animals injected with saline plus near IR irradiation, animals injected with gold, and then animals injected with gold and then treated with near IR radiation at the VM. In 2 animals, the VMs were completely gone. And in 6 animals, they were quite small and pale. When we looked at these VMs in histology, what we could find is that animals that were not irradiated, again, the blood vessels were very abnormal. So here I just took in PowerPoint and outlined the blood vessels. And as you can see, they're very abnormal, and they're derived from human cells. When we treat with photothermal therapy, we can find, really rarely we could find a blood vessel. In fact, we had 8 VMs, 2 were eliminated, so 6 remaining. In the 6 remaining VMs, we had just 1 VM that had just 1 small blood vessel. All of the other VMs looked like this, kind of scarred, no areas of RBC-filled blood vessels, and mostly just scarred tissue. We did cause skin injury that was notable in all animals, although it was relatively minor. So basically, these are animals injected with gold. Here's animals injected with gold plus near IR just at the VM. You can see the VM before treatment. This is what the VM looked like at day 3. All animals began healing at about 13 days in terms of the skin burn. And by 20 days, there was a scar and the skin had healed, but the VM was significantly smaller and sometimes completely ablated. Photothermal therapy is otherwise well tolerated. We measured a number of things. We looked at animal body weight between animals that got gold versus saline. There was no difference. We measured evidence of organ function, liver function tests, pancreatic function, renal function tests, all similar between treatment groups. We looked at serum chemistries, also similar between treatment groups. We measured organ weights, and again, no difference between treatment groups. And then we did look at all of the organs by histology. And while we did find evidence of some gold accumulation, there was no evidence of inflammation or organ damage that we identified. And this is consistent with other papers and people that are using gold more long-term, like for looking, this was over the 20 days. People have looked over months and years and not seen inflammation associated with gold accumulation in bystander organs. So that was a lot in a small amount of time, but where are we going next? We're going to use that photo-targeted drug delivery system that I described in the first portion of the talk to encapsulate inhibitors within and see if we can target drug delivery systems to venous malformations. We're optimizing the safety of the photothermal therapy. I mentioned that this method is titratable. So by modifying nanoparticle dose and irradiation conditions, we should be able to get there. And then hopefully moving this into other models. I hypothesize that other models of vascular malformations will be amenable to nanoparticle-based treatment approaches. I wanted to thank Dr. Dan Kohane, who is my mentor and is incredible, and the co-creator of this entire project and very supportive. And then my division chief and the chief of surgery at Boston Children's, who helped support this work. Joyce Bischoff, who's been an amazing mentor to me throughout my journey here. Elisa Boscalo, who helped give us the venous malformation model. And then the folks on this side actually did the work. So I wanted to highlight Claire, who's the co-first author on the photothermal therapy paper, and Michelle, Brian Wayman, and Isabel, who continue to work on this project. Thank you for your attention. I know I speak fast, so thanks for letting me get it all in. If you have any questions, I'm happy to answer them.
That was a wonderful presentation, and you didn't speak too fast.
Okay, good.
No, it was just right. And we'll open it up for discussion, and I'll get the discussion started. Really elegant work, a really nice system. And I was curious about larger nanoparticles, and if within your future directions, if you guys have thought of testing some of the larger nanoparticles and injecting them subcutaneously and seeing if they're selectively taken up by like lymphatic vessels. And this would be a way to specifically target functional lymphatics or lymphatic vessels.
No, you're spot on. We're absolutely literally doing that today, basically. Like yesterday they did it. But we're doing that now because, to my point before, the problem with some of the systems I'm using now is they can release drug for 48 hours, maybe a week, maybe 2 weeks. But we've developed a system where we can actually give like months worth of drug in one kind of system. And so we're testing that now, injecting sub-Q. And we're trying to work between, do we just inject area around the venous malformation, or do we inject it directly within the venous malformation? So we're testing those different strategies, but great question.
Thank you.
And oh, the one piece is that the bigger particles, the reason why like microspheres, for like bigger, larger particles, if you injected those systemically, that would cause a pulmonary embolus. They would be too big. So some of those larger particles will reserve for sub-Q injection.
Hey, I had a couple of questions. This is Brian Sisk from Washington University. I love the presentation, and I love the kind of thinking out of the box of what we usually do. A couple questions. One is, you know, in the mice, it's really convenient because the venous malformation is right at the surface and exposed to light. But a lot of our malformations go deeper. They can invade muscle, bone. They can surround nerves. So I guess two questions. One is, what do you think are the novel approaches to getting the near-infrared light to the affected tissues for deeper lesions? And then number two, given the toxicity to the skin from the heat, what do you think that means for some of these VMs that are surrounding nerves and muscles and other more sensitive tissues?
Great questions. All right, I'll tackle it in a few stages. So the first, in terms of photothermal therapy, at present, using near-infrared light, you're correct. We can penetrate deeper than visible light, deeper than LED light, but not as deep as ultrasound, for example. So the few workarounds to that would be and actually these are already being used, like in the prostate cancer phase 3 trial, they basically have a catheter with a near IR light on the end. So you could think about laparoscopic approaches where you just buzz, you know, you go in and you buzz wherever you want it to go. So that would be one option. But you're right, depth of penetration is a problem. And it gets quite complicated from a chemistry nanomedicine perspective because you basically have to balance mechanisms that are strong enough to either break a chemical bond, like for example, LED light from an energy perspective is a lot stronger than near infrared light and is able to break that DECEM CPP bond, whereas near IR light could not do that. So it's like it's managing the energy output that you can achieve with the depth of penetration, and there's advantages to either mechanism. So that's number one. So there are strategies around deeper lesions, and that would be a catheter-based approach. Number two, what would I say about, I think that, and this is why this is so fun, I think there's probably not going to be a one, if nanomedicine becomes the norm in this field, which I hope it does in my lifetime, there probably won't be a one nano approach fits all because of exactly what you're mentioning, like maybe a venous malformation that includes the upper airway, you might not want to induce that heat and inflammation because that would be a problem. Whereas maybe more systemically delivered EPR-based nanoparticles would be the answer. So I think the reality from my end, and anybody that wants to work with me, is that we're going to have to make a lot of different iterations and be creative. And we'll probably find that there won't be one type of hammer for each type of malformation, and you would have to specifically design the nano approach to the kind of category. Like, is it superficial? Is it deep? Is it surrounding, is the malformation surrounding nerve or not? That would be my answer to those questions. Hopefully it's on point.
Hi, Kathleen. Great talk. Thank you for sharing. I'm Carson Sibley. I'm in the radiology department here at UT Southwestern, and my research focuses in lymphatic imaging. Couple questions. I was pleased to see that you're interested in targeting lymphatic malformations for future work. I'm curious to know your thoughts on approach to delivering the nanoparticles to the lymphatic malformations. And then a second question, do you have any plans to work towards incorporating contrast agents or techniques to visualize where these nanoparticles are?
Great questions. I'll take the second first because I actually just, what I actually had to do, to be quite honest, at this point is start going to the IR suite with some of my interventional colleagues to kind of figure out from My perspective is I take care of these kids in the ICU, so I can see, the patients as they come to me, but I've had to learn a lot more about what is actually out there, and how can we innovate. And so absolutely, one of the things I've been thinking about a lot the past couple months, is trying to design contrast agents, and maybe could we design something that is contrast and therapeutic. And there's a whole science around this. So I'm not inventing this, but absolutely is something that we could think about in the future. And then the second is lymphatic malformations. That I would love to design therapeutics for lymphatic malformations. I've sadly have had a number of patients the past couple months that would have benefited greatly from new therapeutics for this disease. Right now, I'm limited by modeling. So mouse models aren't quite there yet. But I have been thinking about it conceptually. And I think one potential would be cannulating the lymphatics and delivering the actual nanoparticle agents right there. Because without their own actual dedicated blood flow, I don't know that we could rely on, I don't know because I haven't tested it, but I don't know if we could rely on systemic administration to really be super helpful, but it remains to be tested. Hopefully, with models and as they're improving, I mean, Dr. Pascalo is just making incredible models for VMs left and right. It's incredible. So hopefully, over the next couple of years, that will change and we'll have better models for some of these diseases.
Great, thank you. I agree. It's a tremendous problem and in need of innovation. So thanks for your work on this.
Yeah, no, thank you for listening.